let me refocus our attention on why I'm here, what I'm doing. It's been great getting to know Carol and the rest of the NAMI folks that I've had a fortune of talking to. Today, I'm going to talk about something that I think what I'm hopeful for is just opening a conversation about a subject matter that's really important to me. It has been an integral part of my practice for the last, I would say, ever since I started training and doing clinical work in psychiatry, and only really crystallized for me, I think, in my time at the VA, and then especially really affirmed when I moved into a clinic in Santa Rosa that deals with folks who are struggling or experiencing homelessness and have substance use disorders and chronic severe mental health illness. The factor that sort of came out with a lot of these patients, sort of or clients, was a commonality in many cases, not all of them, and it's been something that has actually gained traction in a more broad public health lens, and that is with the effects of adverse childhood events on well-being across the lifespan. The fact that these adverse childhood events, which I'll kind of go into in a little bit, can have a really serious impact on people's ability to thrive in their life as they get older, and impacting mental health, and not just mental health, but employment, housing, and all the rest, and doesn't really discriminate against, you could come from a very well-to-do background or from nothing at all, and the outcomes are fairly similar. I do want to be cognizant of the fact that this isn't a talk about laying blame for anything that we see in our day-to-day lives as either clinicians or caregivers, family members of people struggling or experiencing mental health or substance use disorders. And it's more to just add it to the things that we want to think about when we're managing these cases. And I would say trauma isn't just isolated to childhood adverse experiences, but happens throughout our lifetime and can be a direct result of being homeless, of having a severe mental health episode, being hospitalized, whether you're in the ICU or you're even in an inpatient hospital that may not be very therapeutic. There's a lot of places where we can experience trauma and repeat trauma. So I just want to bring that lens into focus, and I want to cover a few things that I think are a good way to think about this in a maybe just a structured way. So let me just share my screen. And I'm hoping this works. Can you all see that okay?
Looks good.
Good. All right. So the question is, why is it important to think about trauma when thinking about serious mental illness? Well, because it has, like I said, it has an association, and when I talk about mental illness, I just really want to be clear. I think of substance use disorders, mental health disorders as kind of the same bucket. I don't differentiate between the two. I think they oftentimes go hand in hand and are really hard to sort of parse out a lot of the time, especially when there's severe illness happening. Because we get into the chicken and the egg conversation a lot. So I just want to clarify that when I'm talking about serious mental illness, I'm talking about those that are struggling with serious substance use disorders and or serious mental health issues or problems. So if we look at a map of California and just look at childhood adverse childhood experiences, this map shows the distribution of those those adults who are screened for an adverse childhood event and had 4 or more adverse childhood events, which is really the significant threshold to get over 4 or more, and you're really sort of pushing the threshold. So if we see here, Santa Cruz has a relatively high rate of ACEs per their population compared to the rest of California. And you can see that, other counties that Mendocino, we don't have data for places like Humboldt County, but you can see up in I think the Shasta area. I don't have all these counties memorized. And then just a couple down south with also some high numbers there. And I'll get to why I want to point that out as a significance in a couple of slides. So what do we know about ACEs? There are 3 sort of categories. I think a lot of people think about abuse as being an ACE, but that's not just all it is. It can be neglect as well. And then there's somebody in the household may have a mental health issue. Somebody might have been incarcerated. There could be substance abuse that they were exposed to. Even mother's exposure to trauma can also be considered an ACE. And then even just the separation of the family bond. So something like a divorce can contribute to this phenomenon. So what are we finding in California about the distribution of these ACEs? Well, most, as we would expect, are around emotional or verbal abuse, secondarily parental separation, divorce. We know that this is just relatively high across the board, regardless of thinking about ACEs. And then secondarily, substance abuse in the household, and then followed by physical abuse. And this is just distribution of number of ACEs, so 4 or more, not a huge number, but you can see that Santa Cruz County is higher because it was, I think, in the 20% range. And so what happens when we are exposed to these adverse childhood events? And again, I don't want to just really keep people's focus on childhood. I want people to broaden that horizon and extrapolate some to later life events that could also fit into this dynamic and paradigm. But so again, this is sort of distribution of ACEs. And then as you have more ACEs, risk of bad or risk outcomes go up. So 4 or more ACEs is what we really would want to focus on when we're doing our work in the clinic and talking to somebody who might have this. So when we look at risk or outcome measures as related to ACEs, we see that there might be limited physical activity. The individuals might engage in smoking, drinking, substance use, or missing work. Sorry, I've got a tiny screen over to the side of me here. Physical and mental health issues can be, again, just inaction. I don't know, so physical health, right? So obesity that comes with the lack of physical activities, comes with a risk of diabetes, some depression, and so on and so forth. I won't go into all the details, but as you can see, the effects are fairly broad when we're talking about ACEs. Oops. And so when we go back to this map, again, just to kind of remind you what the distribution is, when somebody has 4 or more ACEs, they're 2.2 times as likely to have ischemic heart disease, 2.5 times more likely to have a stroke, 2 times more likely to have cancer, 1.5 more times as likely to have diabetes. And with with respect to behaviors, anybody with 4 or more ACEs is 12.2 times more likely to complete suicide. Or sorry, not complete, attempt. I take that back, attempt. Or 10.3 times more likely to use injection drugs or substances. 7.4 times is likely to have a alcohol use disorder. So again, this is sort of the distribution of those folks who have 4 or more. So as you can, if you remember on the last slide or one of the previous slides, the average was about 16, and we are above 20 or 20 and above. Sorry, 16 is right there, yeah. Where are we? Here we are. Okay, sorry about that. I meant to hide those slides. So again, here we are in Santa Cruz, and this is a map of opioid overdose death rate in California in 2015. And as you can see, we have a similar distribution of these, of a serious adverse outcome that lays right on top of that map of California and the ACEs numbers. And this isn't isolated to opioid overdose deaths. If we look at methamphetamine opioid overdose deaths, we see this is an interesting map, and it's available to anybody online. It's called the Opioid Dashboard, and it gives you all sorts of, if you love data, it gives you all sorts of really neat things to look at with respect to substance use and overall drug use, or whatever it might be, even prescriptions of certain medications. So if we look at this map, this is called a bivariate map. So here on the x-axis, we have number of deaths for all drugs. So if you're low, you would be here. If you're high, you would be here. And then it plots it against deaths associated with another substance. And here I choose psychostimulants with abuse potential, and that is methamphetamine. And so if we look at where we are on the map in 2019, what we see is that because we are this color right here, that means we have a medium risk of death from all drugs, but a high risk of death from methamphetamine. And if we compare, and what's really nice to see, and this is really, I would say, all the work that SafeRx has done in Santa Cruz County. I don't know if folks know SafeRx, but they are a group of clinicians and dedicated individuals who have been working on reducing the prescription of opioids in our community, as well as increasing our medication-assisted therapy for opioid use disorder in our community. And when you look at, I have all the slides, but just in the interest of time, I didn't want, and the focus of today, I didn't want to go into detail, but I want to call out that this used to be in 2015, this was dark blue. So we were here. So in about 5 years, we've moved the opioid death rate down to medium. And so when you look at this map, as it relates to not all drugs, but opioid overdoses, sorry, if you look at the opioid overdoses here, this is actually a medium, and it's the same color, and it used to be this dark purple or dark blue. So a lot of good has been done in our community. But again, we have work to do on methamphetamines, and that is where SafeRx is starting to focus their work. Again, I just kind of want to make that association with trauma and the map that shows that wherever there seems to be a higher number of ACEs, we're having a higher number of deaths associated with substance use. And we know that ACEs also cause and can be not cause, but are very much linked to mental health issues as well. So I think if we actually mapped out number of people struggling with psychiatric illness, we would see a similarly distributed map. So there hasn't been a lot of work done on the association between trauma and things other than just PTSD, so post-traumatic stress disorder. My years at the VA made me an expert in PTSD and all the things we can do to manage, to diagnose, treat, and manage PTSD. It takes a lot of work. And I'll get into a little bit of why that is in a little bit. But what I often saw in my practice was people that would come in with a diagnosis of bipolar disorder, schizophrenia, schizoaffective disorder, and were really, really struggling. They had a lot of substance use disorder troubles as well, and were never really responsive to the medications you would normally treat schizophrenia, schizoaffective, bipolar disorder with. They would have somewhat of a response, and then they would just drop off. And it would be a very chaotic and tumultuous journey as we tried to figure out what was going on. So I often scratched my head and I said, well, what could be the link between trauma and psychosis that I'm seeing that I just can't seem to get a handle on? Because when I asked them about their lifehood or their lifetime trauma exposure, I'm often getting a story of they had several experiences or one or two experiences that were really impactful in their lives, and oftentimes never talked to anybody about it, not even their parents. So it's not that it happens in the home, it could happen outside the home, and they've never talked about it to anyone because it was so shameful and sort of a lot of guilt around it that they just didn't want to talk about it. So I kept asking these questions, and only recently have we started to see some studies looking at this. So when we look at neglect and emotional abuse, nearly 1/3 to 2/3 of patients experience psychosis when they've experienced neglect or emotional abuse. We often see an association of positive and negative symptoms, as we call them in schizophrenia, with developmental trauma. So positive symptoms are hallucinations, delusions, disorganized behavior. Negative symptoms being that amotivation, that apathy, that alexithymia. They just don't feel anything. It's just a blunted affect. And also that I think this is fascinating. The study showed that, or studies have shown that 1/3 of all cases of psychosis can be attributable to their childhood trauma. And then when we link that with an ACEs score, we see that for every ACE that you might have experienced, you become 1.2 to 2.5 times more likely to have an increased risk of a hallucination, or more likely to experience a hallucination in your lifetime. And so if you have 7 or more, it's a 5-fold increase in risk of reporting hallucinations. And I kind of want to stop here for a second, because it's important to think about, well, what is that, and what is that relationship? And I will get into it in a little bit, but I want to highlight part of trauma can cause dissociation. We dissociate as a protective mechanism. It saves us. It sort of protects us from the pain and anguish that can happen when we're experiencing a traumatic event. And so in dissociation, grasp of reality and different sorts of things can start to happen in the brain that are very atypical, and things like dissociative fugue, where people forget where they were for days or weeks on end, can happen. So when we look at outcomes and management profiles of folks who have experienced developmental trauma in their lifetime, we see a higher risk of poorer prognostic outcomes, including greater symptom severity, higher rates of hospitalizations, poorer responses to treatment, which then can lead to oftentimes increased doses of antipsychotics and mood stabilizers that you would others find somewhat atypical in the population that you don't always have an easy time of treating, but can be much more simplistic in their treatment profile. When you identify somebody with schizophrenia that doesn't have trauma, it's sometimes treatment can be difficult, and the exacerbations themselves lead to further difficulties with treatment and treatment resistance in their own right. But when you start with trauma and then have psychosis on top of that, it can lead to a lot of great difficulty in finding medications that work. And I'll again go into that in a little bit. And something I do want to point out to folks in this group is that people often on the clinical side are not asking these questions about trauma. So there was a study that reviewed a lot of charts after interviewing patients who identified as having experienced trauma in their lifetime. And their chart review of all these patients, when they went to the clinics where they're getting treatment, they found that less than 1/3 of the abuse and neglect identified by the researchers had actually been ever documented in their mental health files. It doesn't mean that they didn't ask the questions, but it's not being documented, which to me means it's not valued as a really important part of their history. So again, it's something that we should be talking about and investigating, especially when we're running into treatment-resistant issues. And at the risk of getting too nuanced in the science behind the effects of trauma, I think this is a really elegant study that shows the link in both a behavioral and physiological manner. So this study is looking at mothers who have had a child and have experienced a range of ACEs in their lifetime. They're taking their 18-month-old baby and doing some tests with them to investigate what is the impact of a mother having experienced a number of ACEs in their lifetime on the behavior and physiology of their infant. And so as we see here, as ACEs scores go up, we see an association with greater telomere erosion. Now, telomeres are the little protective caps that sit at the ends of our DNA when our DNA is all bundled up and protected in our cells. The telomeres protect the DNA from all the bad stuff that's floating around in the cell. And as we age, telomeres erode, and so part of aging and our ability to regenerate our cells and have healthy organs is affected by telomere length and integrity. So as we see here, telomere erosion goes up with ACEs, and then in association with that, we're looking at externalizing behaviors in children in an 18-month-old. So as we go up, externalizing behaviors go up, telomere erosion goes up. And what happens in somebody that's 18 months old, such an important part of our life when we're creating that secure bond with our mother or father or any caregiver that we're living with. That is an important part of our life. So if that's disrupted because innately that child from a congenital level, that child is exhibiting externalizing behaviors, you can imagine that a mother who may not be actually getting treatment themselves or effective treatment for their own trauma that they've endured over a lifetime or their childhood, may be struggling to deal with a child who has an externalizing behavior. And then physiologically, because their telomeres aren't very robust, they're now going to be more vulnerable to aging effects. And that could just be, even metabolic issues or other sorts of issues. So I think this is a very powerful study that shows the link between not just an individual themselves experiencing trauma, but if their mother had, and how that's passed on generationally. So to shift gears a little bit, when we're confronted in the clinical setting with what are we looking at in front of us, you know, we have all these nice algorithms and symptomatology or symptom lists that we use in the DSM-5 that really hasn't evolved that much since the DSM-3, so our Diagnostic and Statistical Manual for Psychiatry. Hasn't really, I mean, it's had some really important changes, don't get me wrong, but in terms of our big three sort of areas, anxiety, psychosis, and depression, and I include bipolar and depression, the criteria really hasn't changed that much. And I think we're still struggling with our diagnostic system and understanding, well, what is depression, what is psychosis, and what is anxiety? And when you throw trauma into the mix, it is never more apparent that this is the case. So if we look at a major depressive disorder with or without psychosis, the effects of trauma can often lead to avoidance and negative emotions. And so that's isolation, low motivation, and hedonia, which is seen in depression. So there's a major overlap there. When we look at bipolar disorder, you can see somebody in a manic state might exhibit insomnia, impulsivity, risk-taking, mood instability, and this can be seen in trauma too as a state of hyperarousal. In schizophrenia or schizoaffective disorder, the other sorts of symptoms of avoidance, dissociation, so these unconscious systems of or mechanisms of avoidance, such as dissociation or distorted cognitions, hypervigilance, could be very much seen in folks who look like they are experiencing schizophrenia or schizoaffective disorder. For panic disorder, intrusion of thoughts, and they can be sort of linked. This is more of a link than an overlapping of symptoms, but we want to think about, well, where is it coming from? Why does this person have such bad panic attacks? Rather than just out of the blue, there's got to be a connection, and we should be thinking about trauma as a connection. For generalized anxiety disorder, negative emotions and hyperarousal, both those two symptoms can result in insomnia and fear-based thinking. And then panic disorder, generalized anxiety disorder, can be associated with agoraphobia, and that avoidance, that intrusive thought process can lead to isolation and a lot of negative emotions as a result. Specific phobias, again, intrusion and avoidance associated with trauma. Even just simple adjustment disorder, that their ability to manage day-to-day stressors. Adjustment disorders usually just don't come out of the blue. They're struggling because their coping skills aren't that great. And so there's a lot of subclinical elements of trauma that are present in adjustment disorder. So we should be thinking about that when we're seeing these folks. These aren't acute stress disorders, a diagnosis associated with PTSD. It will predate PTSD. It doesn't always have to, but most likely it will. And then dissociative disorder. So these DIDs, dissociative identity disorder, can be linked to trauma as an unconscious dissociation as a mechanism of avoidance. And this is kind of an obscure relationship, so I won't go into fictitious disorders or malingering. I don't think that's really something that we're dealing with in this environment. So when we're thinking about how to treat trauma, the VA, who's the expert in trauma, is very clear. Therapy is what is the most effective medicine for folks experiencing trauma. And I missed a slide here, so I apologize. And it was showing just the relative effect size of an antidepressant compared to cognitive therapy. And we look at effect sizes to understand what we expect when we're treating somebody to predict how likely it is going to be effective. So an effect size of about 0.4 to 0.5 is mild, an effect size of 0.8 or 1 is pretty good to moderate, and anything 1.5 and above is really, really good. Well, therapy in trauma is about 1.4, and giving somebody an antidepressant is about 0.4 when we're treating trauma. So I just want to highlight that therapy is what we start with, and then we move on to other options and augmentation strategies should trauma-focused therapy not be working or not appropriate at that time because the symptoms are too severe. But when we're thinking about medications, we want to think about two things. One is that antipsychotics do not work in trauma. They just don't work. The evidence is clear. And in the setting of treating PTSD that is severe, oftentimes we reach for an antipsychotic. And the evidence, again, just shows that that isn't beneficial. And here, the evidence shows that there's that maybe cardiometabolic risk, so that's stroke, diabetes, cardiovascular disease, and obesity can be increased. So the risk that antipsychotics have with our metabolic system and our cardiac systems may be increased in PTSD. And if we think about what the slide showed earlier, and the telomeres being less robust or their integrity being compromised, this could actually be a theory you could generate is maybe it's the effect of not only my trauma, but what we know is generational trauma or intergenerational trauma. This is looking at benzodiazepines in the treatment of trauma. This is a large, what we call meta-analysis that takes a lot of studies that looked at benzodiazepines in the treatment of trauma, and it's a complicated slide. The take home from all these studies is that when we use a benzodiazepine to, in this one, treat somebody diagnosed with PTSD, the effect seems to suggest that it actually makes symptoms worse when treating PTSD. If we're looking at just whether or not they help with trying to alleviate patients who have PTSD. So I'm sorry, this one is given to patients who have experienced a trauma. So it seems to make the likelihood that they get better worse. If they already have diagnosis of PTSD, it's showing that there's no positive effect, overall effect of giving a benzodiazepine to somebody with PTSD. And just to be clear, when the bars cross this 0 y-axis, it means that the study showed no significance one way or the other. So when the pooled analysis shows crossing the bars, that means there's no significance one way or the other. And this last one is just looking at benzodiazepines in anybody with PTSD or a history of trauma. And it shows, again, the pooled analysis shows that no real evidence of any benefit. And if they just take the randomized controlled studies, if this is the pooled analysis, shows maybe it's harmful. If they pool the really robust studies, it shows no effect. So what we know in people with trauma is that they are at risk for substance use disorder. There's a direct correlation between people with trauma and developing a substance use disorder. What we know about benzodiazepines is they are very risky for creating substance use disorders, not only just with becoming dependent on or developing a benzodiazepine use disorder, but also developing other substance use disorders, because benzodiazepines are often used with other substances. For resources on trauma, again, the VA has a really, really comprehensive education program, not just for veterans. It is actually for non-veterans as well, and caregivers and the like. So if you're interested in learning more, I really encourage you to take a look at this website. The folks just over the hill are the folks that actually manage this. It is the National Center for PTSD. It is just over the hill at Stanford and the Palo Alto VA. Other places that have really good resources are NIMH publications, and they're available in Spanish as well. So that's all I have. I do hope I presented, and I'll stop sharing here if I can find where I am on my computer. I do hope that was helpful for folks to kind of go through, and that again, this isn't sort of talking about, and I'll be honest, I got feedback from some folks. It's not about the schizophrenogenic mother. It's not about this sort of very archaic concept of, well, who's at fault. It's, we have a system of care, and we need to be broad in our approach to everybody that walks in the door. And I just, whether it's your own personal experience, or that you're talking to a friend or a family member and having conversations around, gee, things just don't seem to be working and I don't understand why. Maybe thinking about trauma could be a helpful lens to look through and come up with solutions as a result. So I'll stop there.
Thank you so much, Dr. Threlfall. So I'm seeing some questions in the chat, which I will get to first, but I also kind of want to try something different, just because I think this is a topic that I think a lot of us have some things to say about. So I want to give y'all a chance to ask your own questions. So I'm thinking, let's do this. If you have a question that you want to ask Dr. Threlfall directly, use your hand raise feature. So that looks like, for most of you who are on computers, bottom of your screen, there's a button that says reactions. If you press that button, one of those reactions is raise hand. Linda's got it. On an iPhone or an iPad, it might be under more. So click more and then click reactions and then click raise hand. I will call on you when we're ready for your question. For now, I'm just going to read the ones in the chat so that we get to those first. Please keep your hand up and I'll lower it when we get to you, and then you can unmute and just ask Dr. Threlfall directly. This is just a little experiment because I think I'd love to hear from some of y'all. So first few questions in the chat. There's one in the very beginning. I know you spoke a little bit about this, but this was maybe more locally directed. What resources are available to our seniors, homeless, and veterans in our community? With the closure of Dominican Hospital Behavioral Health Unit and Restorative Health Unit on Frederick Street a number of years ago, this population has lost a lot of support. As a medical professional, I see more of this population come through our local hospital with next to no support or follow-up.
Wow, that's a big question. So I am still learning our Santa Cruz County community, and haven't honestly even got into the space of what are we doing for our older adults who need support living in the community, both living independently, supportive care, skilled nursing, and memory care. And I say memory care is sort of a catch-all for people that are experiencing dementia, which isn't always just about memory. And I think COVID has taken all the oxygen out of the room for something that has been bubbling along for probably about a decade, or at least has been identified. The Institute on Medicine did a big study a long time ago highlighting all the things that were not doing well in geriatric medicine, and how we have a workforce issue, we have a system of care issue. People can't afford to get the level of care they need in order to either remain in their home or to have a care home that they can go to. I don't think there's anybody in this room that hasn't had a conversation or and directly with either a family friend or a family member who has been in this position where they just can't find a place to place an individual or get the support in the home. So I don't have a good answer about what are the specific resources, and I haven't even looked. And most counties have like a senior resource guide. I imagine our county has one through Adult Protective Services, or it's not Adult Protective Services, it would be the Agency on Aging. They're always called something different depending on the county, but so that would be the first place I would go if I was thinking, oh goodness, I need to figure out what if I had a resource need, I would go to the Senior Resource Guide for our community. The need to stand up an infrastructure that would support our aging population, which is aging at an accelerated rate because of the baby boomer sort of phenomenon. We're going to see this get worse before I think it gets better. And there are so many organizations clamoring about this, both locally, and I say locally with respect to California and the national stage, and I do believe that's gaining momentum. I think people are listening more. We continue to get our funding supported for these efforts and through Congress, but also hindering our ability to get real change made in terms of funding as a Congress that can't agree to do anything. I mean, we can't even agree to, give people support they need and create an infrastructure bill that would actually include these sorts of things. So I think the infrastructure bill has some hope if we can get it through. But as you all know, Congress has been really stuck over the last nearly half a decade, or nearly, almost a decade, in terms of its ability to move and be agile with respect to national health crises. So I would just say that as I continue to learn and take care of some more urgent matters that are right in front of me almost on a daily basis, and I get to learn more about our community, this will be a very important piece of what I hope to focus on as I put some other pieces in place. I hope that was all right of a response. I know it's not really satisfactory.
Thank you so much. And just from my own personal experience, I wanted to point folks to a couple organizations. We have a VA here in Santa Cruz County, Veterans Association Santa Cruz County, and we also have the Senior Network Services for seniors specifically, along with the NAMI peer support groups for anybody with mental health conditions, any individuals with mental health conditions. That can be trauma, mental illness, any kind of mental health concerns. I can post those links in the chat, but those are some organizations that come to mind. And if folks have other ideas, please do put them in the chat. So a couple more questions. Let's see, we got, I think, 4 or 5 more, and we got about half an hour. So we'll try to get to all of them. Linda asks if there is MAT for meth. I heard UCLA is developing, but haven't heard anything recently.
So we do have a program at the county where we're using a couple of medications and contingency management to help reduce folks' use of methamphetamines. The evidence is not that great. It's fairly weak. It's using either mirtazapine, otherwise known as Remeron, which is a pretty well and true tried antidepressant that has some side effects that we actually use to our advantage. One is it helps people sleep if they can tolerate it, and it increases appetite in some. And for the same reason, we watch out for those side effects. But that is one of the medications. The other medication is bupropion, otherwise known as Wellbutrin. And that medication, again, is an antidepressant, sort of an atypical antidepressant compared to the SSRIs or SNRIs. And it's shown to have, I think, more evidence behind it than Remeron or mirtazapine. And then it's the contingency management, which is basically, it functions kind of like an opioid use map program, in that people are encouraged to come in, get a urine drug screen, see a clinician, either a therapist or a counselor or a case manager or a psychiatrist or psych nurse practitioner, and usually go to a group if they're running a group, and then they might get a prize if they dip their hand in a jar and pull out a piece of paper, and it might be an affirmation or a little bit of money to spend somewhere. That has the most evidence. So a contingency management program has the most evidence for reducing methamphetamine and, in fact, most substance use treatments. So we are doing that at the county. So Dimitri Backus is our medical director at the clinics, our community health clinic at the county, both Watsonville and Santa Cruz. And so if folks they have to be enrolled for primary care there, but they can get enrolled and join this MAP program. And the Safe RX committee is interested in trying to roll this out across our health centers currently. So
Thank you.
Mhm.
Next question is about the antipsychotics not working for trauma. Michelle asks, do you have data that we can use that antipsychotics do not work? Each time my loved one is hospitalized, she is put on mood stabilizers, antipsychotics, but has been diagnosed with complex PTSD.
Yeah, so there is data to support it. If you actually go to the PTSD, the VA's PTSD website, they have all sorts of resources that can help you. If you want to contact me directly, I can provide you with some of those details because I have a lot. And the evidence is, there was a study way back when that risperidone or Risperdal could be helpful, but that has not really held out over the years. And at the same time, in an inpatient setting, sometimes we're doing things that are not exactly evidence-based, but that should be kept in mind when prescribing an antipsychotic for something that is complex PTSD, especially if it doesn't work. So antipsychotics in the short term can be very sedating, and oftentimes they can be used to help control behavior because of their sedative qualities. The unfortunate part of that is that sedating quality can kind of wear off over time, though that dulling effect may not. And I don't think in the setting of trauma, in my experience, it doesn't really keep a cap on those large mood swings and erratic behavior, including psychotic elements that occur in those major swings. So yeah, I think it's hard in those settings to figure out what to do, because honestly, treating trauma, especially when it's complex and it's risen to the level of needing an inpatient hospitalization, takes time to treat that. And right now, I would argue that our inpatient hospitals don't keep people for longer than they need to or can because of both insurance and bed availability. So the pressure on that system isn't working towards the benefit of the individual who's experiencing a major exacerbation. I can't tell you how much this bothers me about our system of care currently. As was pointed out earlier, all these hospitals have closed down over time, and we have fewer and fewer beds. And yes, we want to do as much as we can in the community, but when somebody goes into the hospital, we have to stabilize them and see that they're stable and see that the medications are working and develop a treatment plan with them that is sound. I mean, that's how I trained. And it was sort of overnight that suddenly when I tried to get somebody into the hospital, they wouldn't stay more than 3 days or at least until they just weren't on a hold anymore. most of my patients that I treated on inpatient units in Philadelphia were on voluntary status, even some of the most severe patients. It was the therapeutic alliance that we worked on in that setting. And I think there's been so much pressure on the system for various reasons that we've kind of lost that thread.
So Doctor, this is Michelle. I asked the question. Thank you. You really actually helped me because my daughter's been in the last year hospitalized about 15 times on 5150s. So they probably did put her on the mood stabilizers in the hospital to get her stabilized. But even the psychiatrist, when she's released and she goes into a step down program, they're still putting her on the mood stabilizers and saying she has bipolar. But I've had psychologists who have said, no, this is complex PTSD. I am saying exactly what you were saying. It doesn't seem to be carried through the system that this message is getting to the hospitals. So that's why I asked for the data, that how to approach a doctor who is saying, no, I'm going to do this, and then you're stuck or your loved one's stuck. She's been having to be put on medication because of diabetes, because she gained 50 pounds in a month. So that's another thing, if you could give us a little bit of helpful how to talk to the physicians so that they hear us and don't feel like we're trying to tell them what to do when we don't have the qualifications. Thank you.
Absolutely. Yeah, a precarious situation for sure. This is a conversation that I have to admit I'm a bit of an outlier in. I have this conversation a lot with some very close colleagues, one of whom, is contributes to a lot of the evidence-based psychiatry that we do at the VA. And luckily the VA has sort of sorted this out, but I think in our general psychiatry community, this conversation hasn't been had a lot. And it's something that, again, I'm passionate about as much as I'm passionate about geriatric mental health. And the reason for that is because when I get a patient in the geriatric mental health environment, oftentimes it's a consult for dementia, and the first thing I look at is medication, and I go, well, what's causing their confusion? Well, it's their medication. Let's deprescribe. And it's amazing how people still don't quite understand that paradigm and how medications can contribute to actually worsening behaviors, especially in dementia, but even in this setting where we're talking about trauma. So I think just being curious with a psychiatrist or a psychiatric provider about what if we thought about it differently and approached it from a different angle? Could we get a different result that would keep them out of the hospital? What if we tried to find them a trauma-informed therapist that could really work with them? If they're in a controlled setting, like a step down, that's a place where you could actually test whether or not an antidepressant could work, because what you don't want to do is give somebody with bipolar disorder an antidepressant, because it puts them at risk for developing a manic episode. And I will say that I have taken patients, very complex med regimens, and tried to get them off because the history of bipolar just doesn't seem to fit. They do have a history of trauma, and we work on that shift, and they develop manic symptoms. And it's hard to stop mania when it starts. So I am not saying that it's not without risk to walk down this road, but we owe it to our patients to ask the question, and then carefully in a controlled environment, ask the question and make a change to see if we can get an impact. And I can say that I've had a lot of success stories. So I think it's just being curious, and I'll try to leave it there because I can go on and on about that. Hopefully that's helpful, Michelle. And I'll just say again, I'm happy to share some articles with you if you like.
Thank you. Jen, I see you're next in the chat, and you also have your hand up. Do you want to just ask the question directly?
Yes. So my question is, when someone has PTSD from multiple life traumas and is also diagnosed with very severe bipolar 1 disorder with psychosis, How do you address both illnesses? It seems like with my treatment, it's a lot of focusing on the bipolar, and there's really no focus on PTSD. And do PTSD medications make bipolar worse? Are they contraindicated?
Yeah, well, there's a relative contraindication for sure. And so you, like I just said, you have to be very careful. So you wouldn't stop the mood stabilizers, but you could try to add an antidepressant for the PTSD. But like I said before, it's trauma-focused therapy with a skilled clinician that is really where the money is. And it's so when we think about from the clinical side, when we think about bipolar disorder, we think about, well, what ways, so, okay, so we have you on a mood stabilizer. Well, why do we have you on a mood stabilizer? It's to stop the mania and or the depression from setting in. Mania happens, what we want to do is make sure you're sleeping well, making sure that you don't have a lot of stress in your life, or if you're exposed to stress, that you know how to handle it and deal with it. What we know about trauma is dealing with stress and life as it happens can be very difficult and can contribute to insomnia. So it's focusing on those symptoms and really targeting those symptoms to the best we can with the medications that can target them, but really starting with working with a therapist who's skilled at providing evidence-based psychotherapy for PTSD. And that's the real key. It can't just be any therapist doing any therapy. It has to be, you know, and it's not to be manualized. I don't want to make it sort of this cookbook thing, but they have to be trained, and then they use that training to work with the individual who needs some nuances here and there. So that would be my answer. And I would again argue there's not enough trauma skilled therapists anywhere. There are collections of them in certain places when there are centers for PTSD and stuff like that. But in general, I think we have a lot of work to do to train people up in this type of treatment.
Thank you.
Oh, and I just want to say one thing too. And so we should be careful about adding medications, because more than 3 medications, you're starting to get into interactions with medications that could be contributing to mood instability in its own right. So that's really important to keep in mind when making those decisions.
Pam, I see some feedback from you in the chat that I don't think I could quite do justice. Would you be willing to unmute yourself and share your thoughts directly? Are you there, Pam?
I can figure this out. Can you hear me?
Can you move a little closer to the computer maybe, or to the microphone?
Can you hear me?
Oh, that was worse somehow.
Okay, well, it was just a comment because it's a big subject, but I think he was saying that about 1/3 of the psychosis that they've been looking at is showing to be related to trauma. And it seems like, especially to a group like NAMI, or say if we're presenting to law enforcement for training, to word it that 2/3 are not, simply because there's so much stigma, and this is a family group, and it would discourage a lot of people, I think, a lot of family members from seeking treatment if they felt that this was the view, that it's a family trauma possibly. And I know the doctor said, no, he's not saying it's family trauma, but I think that's how it might be interpreted, that trauma in childhood relates back to family dysfunction. And in so many cases, it's not. And so I'm just worried that if this becomes the focus of healthcare workers, trauma-based treatment, it's going to scare a lot of people, families, from coming in to get their loved ones treatment. And so I guess if there were a question, it would be, how would you deal with that with family members?
Yeah, so I think, and thank you for asking the question, and this was brought to my attention as well when I was suggesting I might talk about this subject. So I'm not caught off guard, and I appreciate it. You're absolutely right. How do we not swing a pendulum the wrong way? And you know, where in our world has the pendulum not swung too far in one direction or another lately? I mean, it's just we are so prone to doing that. So I think that the point about a third being attributable to trauma is to say that we should think about the whole constellation of potential causes for somebody who shows up with a diagnosis that could fit into a puzzle. And in the cases where, gee, it smells like, it walks like, it talks like, let's say schizophrenia, and I know that's not a very nice way to say that, but if in that setting in your brain as you're kind of going through all the different things, and then you do the usual treatment and it doesn't work, and then you change it and it doesn't work, well then, okay, well, what did I miss? Could I have missed something? And the danger in that is, you know, I think there was back in the 80s and 90s, we had this surge of hypnotherapy and people having these repressed memories that were either false or true, and we don't even know. And then suddenly families are broken apart because of this, for terrible reasons. I mean, tragic results of a misguided approach to treatment. So what I would say is that it's more about we need to ask the questions and provide support to, and not to blame a family for anything. It's to do that would be to do the opposite of what our goal is as providers as clinicians is. It's to help people to the best of our ability live a full and fulfilling life and have the best quality of life they can. And if parents, let's paint the scenario where a parent may have had a substance use disorder and been somewhat disconnected, and that did result in something. The judgment shouldn't be placed on anything other than how can I help you feel supported in what role you had and what role you currently have. When we're seeing parents in the primary care setting, and we see that they may not be parenting very well, we should be paying attention to that and understanding, well, how can we help this parent better so that they don't? And it's more from almost a preventative place that we want to focus our attention so that we reduce the amount of negative impact that these childhood adverse experiences can have. And when we're seeing somebody in our clinic and brought in by a family member, it's always our job to make sure they're safe. It's always our job to make sure that if they're not safe, that we do something about it. And then there are legal components that were required. But when you have somebody who expresses a trauma, that is a hard thing and a hard space to get to. And then it's dealt with very delicately. And I don't think I've ever met anybody that sort of started going, well, let's get those parents or anything like that, or not offering support when there's clear difficulty happening. And again, it's not to say that, you know, I think family dysfunction is the wrong way to think about this. It's more about, is there an event or series of events that happened in a lifetime that could have contributed to why this treatment or this diagnosis may not fit, rather than I'm looking for the cause and to focus my attention on that. It's more about, were there some events that happened? And I don't know, I'm a parent of two almost teenagers now, one teenager, one preteen, and all their friends and families, there is no place where people aren't exposed to something or other in their lifetime. And I think we just need to value that is a part of life, and that we should bring that into a space that destigmatizes it, that doesn't vilify parents for doing the best they can given the resources they have, and just to really put a pin in it, that the cycle of trauma is just absolute in our world. And I just, in my experience, working with very, very sort of difficult cases, that is always very evident, that it's this cycle of trauma that they never had a chance to begin with because the parents never had a chance to begin with, and that parent never had a chance to begin with in the most severe cases. And then you can just bring that all the way back and say, you know, sometimes things are difficult in life, and unfortunately children get exposed to those difficulties and it can have an impact. Now, I don't know what the data showed in terms of severity of psychosis when you have a third that experience, but if you think about it, almost, I don't have the exact number, but a really, really high number of people experience hallucinations in their lifetime. And there's nothing wrong with them. They just experience hallucinations. They are functional, full living human beings. And where that hallucination came from, I don't know. Could have been from something that happened in childhood, maybe. But does it mean that we need to do anything about it? No, it just needs to be normalized, that we don't need to treat this. We just need to make sure that you're a functional person. And if you're struggling, we're here to help. That's sort of a long-winded way of maybe an answer.
Yeah, I appreciate that. I guess I'm a little worried about individual clinicians or healthcare givers that might approach everyone coming in as the first thing to go to is, oh, okay, this person is coming from a traumatic event in their family.
Mm-hmm.
And then that's a difficult way for a family member to start off.
Yeah, absolutely.
With a doctor or any kind of a caregiver.
Yeah. Yeah, I mean, so the approach should always be the whole person and the whole history. It's not just one focus. And I agree. We can be guilty of, you know, the word escapes me, but sort of diluting or deconstructing what we do into a way that we boil it all down into one thing. I think that's done to make it easy, and this work isn't easy. So that's what my message to folks is. So I'll stop. Sorry.
No, it's good. I'm glad it was good listening to this. Thank you.
Mm-hmm.
Thank you. And just a time check for us. We have about 10 minutes left. I think we can go a little bit over if there's more questions. We have about 3 more questions left. And I see Cherry, then Patricia, and then we got a couple in the chat. So Cherry.
Thank you. I think I heard you correctly by saying treating psychosis with trauma using antipsychotics is not helpful, but therapy is. But I'm curious, given a reality check with the county's mental health system, having consistent, regularly scheduled therapy and/or psychiatric appointments with a county psychiatrist who can take that time and probe an individual's history and chart that with follow-up insight and treatment. I think you're talking apples and oranges. And I'm wondering, with your vast experience and great insight into how this all works in an ideal world, or theoretically, how you might see that infiltrating our existing system.
It's about education, and you know, I've already spoken to the primary care providers through our Integrated Behavioral Health Action Committee, through the Health Improvement Partnership of Santa Cruz. I've given, so the presentation that I gave you, it's actually 50 slides that I have in there, and I presented all this same material to them, and it was amazing how much conversation it generated. So it's getting people to think about it first and foremost, educate them about what the evidence shows, and then looking at our system of care and understanding, well, how are we supposed take care of this particular population. And at the risk of kind of maybe speaking out of turn, expecting people to, you know, when their symptoms get worse for whatever reason, to change their provider from the community in which they are living and seeing their primary care, and they have their therapist that they go to on a routine basis, and suddenly they have an exacerbation. Now you meet criteria for a higher level of care at the county, and expecting somebody with a history of trauma and severe trauma at that to now move all that care, mental health care, away from their medical home into a place where they have to meet a new person, a new therapist, new case manager, new psychiatrist. It's unreasonable. It doesn't make any sense to me. For the very nature of somebody who's traumatized has a difficult time sharing their story and connecting with others. Somebody put in the chat, is there an attachment disorder related to PTSD? Of course. I mean, if you have a ruptured attachment because you didn't have that opportunity as a child to have a secure attachment, absolutely. And so it's shifting how we do care. You know, where does the patient sit? And I'm sorry I use patient. I hope that's not seen as the wrong word in this setting, but the individual who has who is struggling needs to be, we need to go to them where they are and be familiar as well, right? Not sort of like you need to go over here, because at their worst, at an individual's worst place, that requires a lot of organizational sort of you know, inertia to do that work, to go see somebody new, to go to a new system of care. And so I think it's really focusing on where is the individual themselves. Let's go to them with the resources that we know can be helpful in these settings, and put people in the right place rather than expecting the individual, put the treatment team in the right place rather than expecting the individual to move themselves into treatment locations. And it might be a bit controversial to kind of make these statements, but that's the way I see it. You know, and at the VA, we took care of our folks that had severe PTSD from combat trauma because we had everybody that could do the work, because the VA has trained everybody, all their therapists on PTSD focused therapy, trauma focused therapy. We have the prescribers are all trained on it, and so we have a tiered system within the VA that you go through in places that have developed this, and you get the treatment you need where you need it rather than, oh, you've got to go over there. So it requires a big redesign and thinking about our resources. And luckily we do have CalAIM, which is a reconfiguration of mental health in the state that I think can be a real opportunity to make that change happen.
Thank you. And Dr. Threlfall, can I ask if you can stick around until maybe 8:10 or 8:15,
Sure.
just because we have a few more questions in the chat. Okay, thank you. And Patricia.
Yeah, I think I wanted to, if I don't mind if I just say a couple things, I wanted to tag on to what Pam had brought up about this idea of maybe being the trauma piece being a little off-putting to families, perhaps. And again, I am no clinician and I don't know the science, and you are so versed in this, but I mean, maybe it's a how you package it sort of situation, combining nature with nurture. Nature of the brain,
Yeah.
where one child can really withstand with great resilience some trauma with no negative outcome. We've seen it. And then the opposite of that. So maybe it's kind of, I don't know, maybe it's feels a little heavy on the trauma, maybe that being the nurture part, but the nature has to be there too, clearly.
Yeah. Absolutely. I'm a nature nurture person. Always got confused why people say it's one or the other. It's sort of like, if you know Alzheimer's research, it's like amyloid, no, tau. And you're like, why are you arguing about which one it is? Just get together and understand what it is we're talking about, rather than fight for resources. It's nature and nurture. Yes, what I'm talking about are the people that predisposed, and that's why I showed that slide about telomere length, right? That's a nature piece, that they had a change in their physiological makeup that wasn't affected by anything other than having a mother who was exposed and had a change in her genetic makeup herself. So it is flowing through in a nature way, and then it's molded potentially into something through the nurture. We are all sort of, in my belief system at least, and I think the science supports, is you're given sort of a general mold, and then life comes around it and starts to shape it in ways, and sometimes it works well and sometimes it doesn't, and some areas you do really well and some areas you don't do well at all. And it's not one or the other, it's not black and white, it's not binary, it's very fluid. And so this is focusing on those who struggle the most, who have likely had that nature piece at a disadvantage, and then the nurture came in and really kind of contributed in significant ways.
My question in the chat too was, well, it was a little bit poorly said, but here in Santa Cruz, it seems that there's a real availability on some levels for some patients or clients to find doctors or providers who are seemingly pretty good at diagnostics, very good at prescribing a lot of things. When you said more than 3, I was thinking at one time, I think my daughter was on at least 10 different medications at one time. And then the flip side, what you started off by saying, is that the trauma piece, if it's truly there, needs some very deep, robust therapy. And in my estimation, it is what is sorely lacking here, a network of deep, robust therapy available.
Yeah. I don't know the community that well from a trauma perspective. It's something that I'm learning about. I lived in Sonoma County still do, for 10 years, and working in the community, and it took me a while to find some groups of clinicians, therapists who were doing really good work. And oh my goodness, when I was able to get my patients, and it was an FQHC I worked in, so it's Medi-Cal patients, into this environment, it was wow. We worked together. We got some good results. So it is important. And again, Nadine Burke-Harris and her mission and life's sort of gift to all of us around ACEs, I think will help us start to continue the momentum around getting people to work on these pieces, not just from treatment of those who have suffered, but preventative measures, right? That we're doing parenting classes, that we're supporting parents who may be struggling. And before people drop off, I do want to just point out, Carol had asked about antipsychotics working for people with psychosis from bipolar and schizophrenia. Absolutely. And I would never tell anybody to stop their antipsychotic medication without talking to their healthcare provider first. That has to be a conversation you have with the prescribing provider. Just stopping them can be quite deleterious, even in the setting of trauma, even if it is all true and it isn't schizophrenia. Oh my goodness, stopping antipsychotics abruptly can create rebound effects and unstable sort of states, that it should be done carefully and thoughtfully with the provider you're working with. So I just want to make sure that that's clear to everybody. And then Michelle, you had a follow-up question about retrain PTS symptoms for patients. So funding for retraining. So CalAIM is the state's new proposal for sort of redesigning mental health in California. It was supposed to roll out last year before the pandemic hit. And we're seeing that, whole person care is a program that has been piloted across the state and kind of fits that CalAIM model, which is really bringing lots of people to the patient where they are to help them with various resources that they need. Yeah, CalAIM, so check it out.
Thank you. Ellen, I see your comment in the chat. Would you like to ask directly, or do you want me to read it? Read it. Oh, Ellen, you're muted.
I'm just thinking about a progression of trauma. You know, when trauma early in life is not addressed or processed, that's when it can develop into PTSD. If it's addressed and processed early on, it may not even develop into PTSD. And so what it sounds like from what you're saying is that unaddressed trauma can become PTSD, and PTSD not addressed, not processed, can develop into these more serious mental health issues. You know, there were some studies that I had read not too recently, but basically the idea that came out through all of these was that early intervention with the support of a healthy family, the support of a helpful family would produce the best outcomes. And so I'm just wondering why it is that families are not particularly included, even if there has been a HIPAA release signed by the client, how it is that clients are not, families are not more included in the mental health system so that they can be supported and be part of the team.
You know, I don't know the reason for that. It's never been my practice nor my colleagues' practice to exclude, you know, those that I've worked with closely over the years, both training and in my other settings, to not include family members, caregivers in the picture.
What we hear
in the room. Sorry, go ahead.
What we hear is that it's not paid for, and I don't believe that's true because both Medicare and Medi-Cal cover 90846, which is family without the patient present.
Right.
So I don't understand.
So I can't speak to the therapy piece as to if you're billing for family therapy. I don't know in a community health setting if Medi-Cal in an FQHC setting, so that's a very specific setting, pays for those family therapy codes. It might be that the patient needs to be there, but that doesn't mean you can't say hello to the patient and conduct the family therapy. It also doesn't say that you, from a cost perspective, yes, it's difficult to do that if you can't get reimbursed, but it doesn't mean you should exclude it to the detriment of the patient, right? So you have to figure out a way to make that work, because caregivers, family members are an integral part of a person's life. I mean, if I could go talk to their employer and go, how are they doing at work? I'd love to know that, but that would just be, that's breaking boundaries. It's not appropriate, right?
But they do come home to us.
They do
24/7.
Yeah. And I'm only going to get so much information.
Yeah. I see.
And I want to test the information they're giving me often, right? You want to say, is this valid? Is this happening? So my practice is, and I try to model this for everybody, is to bring, when I go get my patient from the waiting room, I see a family member, I say, oh, do you want to bring them along? And then they say yes. Sometimes they'll say no. Okay. And then I bring them along. And then if I feel like I need a moment with the patient alone, I just, both there, I just say, do you mind if I just check in with so-and-so and have a seat in the waiting room?
Well, that's good. I appreciate that. And I'm just wondering, now I lost my train of thought. I'm sorry. Oh, well, that's what happens when you turn geriatric.
Oh. I think it happens to all of us at any point in time. It's late in the day. It's 8 o'clock.
A great conversation, Ellen. It was really nice to hear
Yeah,
you speak up on this. Thank you.
yeah, yeah. I think it's really important to do whatever we can to include the families because they do come home to us, and also we need to be trained. That we need to, you know, have explanations about how we talk to our family member that has some sort of a altered state, you know, how to communicate with them, how to help them feel safe enough to let their boundaries down with us. Families need a lot of support.
Absolutely. And by all means, I mean, this is case in point, right? How do I inform a caregiver or a family member about NAMI if they're not in the room, and make sure that they have the support and education they need, right? I mean, we know that caregiver burden is a real thing. It's the older adult research is very clear about the significant impact of caring for a very ill member of the family has. And you know, that doesn't mean that's not happening outside of older adult care. It's happening with a population of folks that take a lot of work to care for and cause a lot of stress in the family and family network and structure. So,
and also one of the things that we've come across a lot in our NAMI community is that family members, when they're feeling helpless, when everything they do seems to fail, they also get burned out, much the way the clinicians can become burned out when they're overloaded. And that some people experience what the burnout as family disinterest or family dysfunction when they're really burned out.
Yeah. It's not easy work. That's all I got to say. And it's regardless of trauma, just the whole, we have to be willing to sort of lean in when we're asked to. I do want to I don't know, Betsy made a comment that I think is really important to note about the conundrum when you get better and you get a job and then you get private insurance. And this is not even trauma. This is everybody, you know, suddenly you can't see your therapist or prescriber anymore because they don't take your insurance as your insurance status changes. I really can't wrap my head around how ineffective this is as a system of care especially for mental health, because it seems that we haven't built a very good system to make sure that people don't lose their providers in this setting. You know, the strange thing in Sonoma County, and I don't know, again, I don't know the private landscape so well in Santa Cruz County, but in Sonoma County, you're better off having Medi-Cal than not having private insurance, because your access to psychiatrists and psychiatric prescribers and therapists is better because there's more people. And if you want somebody private, it's usually cash only and it costs too much, even for somebody with a job and in private insurance, because private insurance doesn't give you enough therapy. So it's a difficult piece, and you know, a one system sort of healthcare system, one insurance healthcare system would really do a lot to resolve this issue, as well as many other issues, especially as it relates to mental health.
Thank you. Betsy, did you have anything to add to that?
I think you'll find that Santa Cruz is the same. You're better off with Medi-Cal in most cases, at least for adults. I don't know, but my point really was also that I'm not sure that Santa Cruz County, they're pretty good with the case management and residential and that sort of thing, but I don't know about therapy, and not to mention highly trained trauma therapists, you know, I don't know. And even if they did, I don't think it's set up in a way where you can have an extended period, which I assume you would need to do what you're talking about, which is to, replace some of the other treatments with working through the trauma. And so I'm just thinking, since you're passionate about this, maybe you can work on this.
Oh, without a doubt, I've got to get my teams in sort of working order first.
Yeah.
We need to work as a team. That's the first thing.
Right.
And then start to build that fund of knowledge, that skill set,
Right.
both from the case management side, the psychotherapy side, and the prescriber side, and then working with our primary care providers at the same time to support them in the work too,
Right.
so that we can, the whole picture is in the same place, so that they're struggling with diabetes or cardiovascular problems or excess weight, that we're understanding from a much more nuanced perspective of, well, these are the things we need to do to help this person thrive, rather than just sort of sending them over here and sending them over there, and nobody really talks to each other when things don't work.
Right. Yeah. Thank you.
Well, I would like to thank you very much, Dr. Alex. This has been a really intriguing conversation. A lot to think about, a lot to contrast to some of the things that we experience or think about. Your passion for making things better resonates with me, and the way you see what you're seeing so far and what you'd like to help create change around is encouraging. And yeah, I think we all learned a lot. We asked a lot of questions, and I just really appreciate your openness and your sharing and your a lot of good information. Anyone else want to make any more comments besides me to thank Dr. Alex? We can just clap our hands.
Many thanks.
Yeah.
Thank you so much for all your information. It was very helpful.
Yes,
And
sorry. I would like
No,
to thank you as well. The current system, my daughter was in it, and it just is not working for people with PTSD because, like you said, they're disorganized and they can't do what's necessary to keep the treatment going. So if they have wraparound services so that they don't have to facilitate each visit, and your experience sounds like it's going to be very welcome. Thank you.
I think Mike and Jean tried to say something earlier, maybe.
Right. Someone else tried to say something?
I thought Mike and Jean might have tried, but that's okay.
Oh,
No, just our thanks.
yeah, our thanks. Yeah, and if we can get to the point where it's okay for a parent to call in to make an appointment without being told, oh no, your loved one has to call in themselves, that would be really big, important, wonderful step.
I agree fully.
Thank you.
The times I've called and said, as a clinician, I've called and tried to do something. They tell me, no, you can't. I can't talk to you about this. I'm a treating clinician. I'm in the circle of care. It's okay. So as a parent, I could only imagine. And yes, so educating everybody on what can be shared, what can be done, and getting families into the middle when appropriate and necessary. Absolutely. All right.
All right, much gratitude to you.
Take care. Have a good
Nice
night.
to see all of you. See you next time.
Bye.
Have a good night, everyone.
Good night, Annie.
Bye-bye.